Thanks for coming. And Aasthaa, thank you very much for also coming, flying from Washington State. So Aasthaa Bansal, she's an assistant professor at CHOICE, which is the Comparative Health Outcomes Policy and Economics Institute in the Department of Pharmacy in Washington. I think you work with Anirban Basu, who has been also in these rounds sometimes in the past. And you have a biostatistics background. You're an assistant professor there, and you've done your PhD. I don't know if you've done your PhD actually on biomarkers, but I know that you're working a lot. In biomarkers and survival analysis. We've seen a lot of your presentations at the medical decision-making conferences. So it's absolutely perfect that we have you present for us here as well. So we usually start by presenting ourselves to you. So I'm going to start. I'm Petros Livanoglu, and I'm a scientist at Tickets. And Joanna is the...
Hi, I'm Joanna Bielecki. I'm a research librarian here, but today also moderator for online participants.
I'm a health economist at THETA.
I'm Suzanne Chung. I'm a research associate at THETA.
Hi, George Thomas. I'm a biostatistician here at UHM.
Lake Fairclough, I'm a biostatistician at Mount Sinai Hospital at the Diabetes Center.
I'm Robbie. I'm in rheumatology, looking at longitudinal biomarkers, but I'm methodologically challenged, so I'm here today.
Ray Cron, I'm a director of THETA.
I'm Yeva. I'm a research associate at THETA and master's student in biostatistics.
I'm Rafael, and postdoc fellow here.
Yeah, I'm a biostatistician.
I'm a Husi, also biostatistician.
Hi, Val. We met last night. I'm associate director of THETA and a scientist with heterogeneous and PhD. Hi, I'm Alexandra. I'm a postdoc fellow at THETA.
Hi, I'm Troy. I'm a research associate at THETA.
Oh, I'm Lucina. We met yesterday. I'm Nitha, a research associate here at THETA and a PhD student at HPME.
Right, take it away. And I think you agreed to interrupt you during.
Yes.
If you have any questions.
Yeah. If you have questions, please feel free to interrupt. Thank you so much for coming to my talk, and Petros for organizing this whole day. So yeah, like Petros said, I'm an assistant professor at the University of Washington in Seattle, within the School of Pharmacy and within our health economics, health policy, and health outcomes group. And now recently called the CHOICE Institute. I am a biostatistician by training, and so I did my PhD and postdoc in biostatistics also at the University of Washington. And I'm also Canadian, I'm actually from Toronto. I moved out to Seattle 11 years ago to do my PhD and just ended up staying. So thank you again. I'm going to talk about a couple of different things, you know, a lot of my research is, current research is in longitudinal biomarkers and statistical methods for longitudinal biomarkers. I'm going to talk about prognostic accuracy, time-dependent prognostic accuracy, and then connect it to ideas of decision theory and clinical utility. So the setting is for screening and surveillance. So screening and surveillance are routinely used in many clinical settings, and where serial biomarkers might be collected to guide immediate medical decisions over time. So at any given time, you know, a biomarker might be collected on a patient and might be used to target treatment by assessing the risk level of that patient. High-risk patients might be targeted for treatment, and low-risk patients might be, spared the treatment. The motivating example that I'm going to look at today is lung transplantation and cystic fibrosis. A lot of my work is actually in cancer, and I'll touch on that at the end. But this example is cystic fibrosis, where FEV1 percentage, or the forced expiratory volume in 1 second, is a standard biomarker of pulmonary function. So the higher your FEV, the better. And it's typically measured on patients at regular clinic visits. And the last measured value, so the measured value at that clinic visit, is used to determine lung transplantation, recommendation for lung transplantation. And so, so the scientific goal, like I said, is, the current value of FEV might be used to make a decision about transplantation, and the decision is intended to optimize outcomes, survival, for example. And so the thinking there is that FEV is a good prognostic indicator of the risk level of a patient. And so a good prognostic marker would identify patients who are at high risk of death or some other adverse event, and then who we can select for treatment. So this is just kind of a visual depiction of what happens in practice. Clinical guidelines recommend monitoring patients every 3 months indefinitely, and sort of a rough guideline is that, if a patient's above FEV of 40, then they're good, and then when the FEV falls below 40, often they're recommended for transplantation. 40, 30 is also used by some clinicians, but there is this threshold for a measurement at a given time that's used often. And so people have said that FEV on its own might not be sufficient for risk prediction. Maybe we should be combining it with other risk factors. So other suggestions have been FEV, age, gender. Another suggestion has been a more elaborate model developed by Liu et al. Using stepwise regression methods, and that's the paper. So what they did was they used stepwise regression, identified all these different predictors of survival in cystic fibrosis, and they showed that this method is better based on log likelihood. And so log likelihood because they used stepwise regression method. But we looked at this and said that, well, model fit isn't directly relevant to the question of identifying high-risk patients for treatment. So they're optimizing this model, they're selecting the model based on how well it fits the data. But our main question is about identifying high-risk patients versus classifying high-risk versus low-risk patients. And so really, the model should potentially be evaluated using measures of classification accuracy. And so this is an idea that was proposed by others, and then we have worked on it further. And what I mean by classification accuracy are measures of sensitivity and specificity. So for, if I have a continuous marker, in this case, FEV is a continuous marker, or you might have a risk score from a model, which is also a continuous marker for the purposes of this measure, this evaluation. You would just, and if you had a binary disease outcome, you would define sensitivity as the true positive fraction, right? So for a given threshold, the true positive fraction of sensitivity is the probability that that marker is over the threshold among cases of people who have the disease or who are expected to have the disease. Specificity is 1 minus the false positive fraction. So it's a probability that your marker is less than that threshold among controls or people who are not expected to have the disease. And then an ROC curve takes all possible thresholds, plots the true positive fractions versus the false positive fractions, and the higher the ROC curve, the better the performance of the marker. A common single number summary of the ROC curve is the area under the ROC curve, or the AUC, which 0.5, an AUC of 0.5 is that your marker is not performing any better than chance, whereas AUC of 1 represents a perfect marker. And just the interpretation of the AUC is that given a random case and a random control, the AUC represents the probability that the case will have a higher marker value than the control. So it's kind of ranking the cases versus the controls. So that was for binary outcomes. It's commonly used in diagnostic settings. Now recall the current setting where we're looking to make transplantation decisions. So over a period of time, you might have decisions that need to be made over and over again using updated values of the same biomarker. So in the diagnostic setting, you have one value of the biomarker that you measure at this time, and then your disease outcome is also measured at the same time, and you're trying to look at the sensitivity and specificity. The setting that we're looking at with longitudinal data is where the marker value itself might be changing over time because it's updated at clinic visits. And the same patient, if you look at an earlier time point, they're controlled because they haven't had the event yet. But then if you look at a later time point, now the disease status might be different because they might be a case because they've had the event. So you've got two things happening. You've got the marker varying over time, and you've got the outcome changing over time for the patients. So, it's also survival outcomes, right? So you might also have patients being censored in this case. So we want the marker to be guiding decisions in multiple time points. And then the question is, okay, so how do we evaluate time-varying prognostic accuracy? So as opposed to classification accuracy at a single time point, how do we look at it over time? And so there have been definitions proposed earlier. There's a definition based on incident cases, which say that for the risk set at a given time t. So at a given time, for patients who are still at risk of the adverse event of interest, we define the cases as those who have the event at that time, and controls as anyone who survives beyond that time, who doesn't have the event yet. And so incident cases are cases who have the time at that time, and the dynamic controls because the set of controls changes over time. And then, so it's this exact same definitions of sensitivity and specificity, but now just for a fixed time point, where your case and control definitions are based on the time you're looking at. And then for using these definitions, we can define the ROC curve for a given time, as well as the area under the ROC curve at a given time. And so we actually have developed non-parametric estimation methods for that, which I'll just give a brief overview of here. So what we're looking at with this incident dynamic definition is, if I'm interested at time t equals 4, for example, I would say, who are the people who experience the event at time t? And those are the ones in gray. And then the controls are everyone who survived past that time. And an excellent marker would be one that has distinguishes between those two groups of people well.
Unless you have a little gray area around 4, so the obvious thing is there's probably one person has the event at any one exact time.
Yes.
To see if you're looking at some kind of moving window around that time.
Yes, exactly. So the gray area around the time point is representing a window. Yes, that's exactly it. Because for estimation, yeah, you might actually just have one or two people at a given time who have the event, but we use nearest neighbor estimation to use a window of cases around that time point of interest to estimate the AUC at that time. Yeah, so the way that we would go about doing that is, for a given case at time t, we would calculate the marker percentile. So that's saying that, where does the case rank in the risk set compared to other people in the risk set? Where is this person's marker value? And then for a given time t, we would average over the percentiles for all the cases at that time. And then given that we typically don't have a large number of cases, we would look at actually a window for estimation purposes around time t. And so that's how we get at an estimate of the AUC of at time t. So that's just a brief overview, and the paper hopefully will be published soon, so you can read a little bit more about it. And then so in that way, we are able to look at the AUC at different time points. So the mean percentile is really an estimate of the AUC, the area under the RC curve. And we applied that to cystic fibrosis registry data. And we showed that here on this plot, I have the mean percentile, or the AUC, estimated AUC across calendar years, so over time. And we showed that using these measures of sensitivity and specificity over time, actually there isn't a difference between just using FEV alone versus a simple model that had FEV, age, and gender versus the more elaborate Liu et al. Model. So even though the Liu et al. Model that had many more variables in it had better model fit, when it came to accuracy, it actually was not necessarily a better classifier than just using FEV alone. And so that's using baseline risk score and looking at its performance over time. And we see that the performance does go down over time, as you would expect it to. The accuracy of a marker that was measured 5 years ago is going to go down over time. So the data here that we looked at was annually updated data from 1993 to 2011 from the Cystic Fibrosis National Registry on patients. And we selected a prevalent cohort in 1993, and we have baseline measurements and annual measurements. So what I just showed you was a risk score based on baseline measurements. But then we also looked at updating the risk score with updating marker values over time. And we see that the time-dependent accuracy for updated risk scores is actually consistently at around 0.9, AUC of 0.9, quite high if you're updating FEV at regular time intervals. And again, as long as you're updating FEV alone versus a simple model versus the more elaborate model actually has very good performance. The performance isn't any different than adding more variables. So FEV on its own is a very good predictor. And if you update it over time, you can maintain that prediction accuracy. So we showed this, but then, but repeated biomarker collection can be costly and inconvenient. You might not want to be measuring FEV every 3 months on patients. And so then the question we asked was, can we determine the optimal frequency of testing? Does FEV need to be collected every 3 months? And so this is the same picture I showed you before, where this is what the guidelines say, if FEV goes down at any given time point below the disease threshold, then act on it. But you might have patients who consistently are healthy, and they might not need to be coming in every 3 months to be tested, right? So the question we asked was then, okay, can we use earlier biomarker measurements to predict future biomarker measurements and potentially enable less frequent monitoring for some patients? So, in this case, maybe instead of coming back in 3 months, wait a year. But the problem with that is that predictions are uncertain, right? There's uncertainty, which leads to decision uncertainty. So if we decide to wait a year, we might be in one of 2 possible scenarios. When we do measure the biomarker again a year later, we might discover that, okay, this was the right decision. It was good to wait because the biomarker value stayed above the threshold that we would act on, and so we avoided all that unnecessary testing. Alternatively, we could find that this was the wrong decision. Maybe we should have tested earlier. So by waiting, we actually maybe delayed treatment for this patient. So that's where the decision uncertainty comes in. And so had we tested earlier, maybe we would have discovered that, okay, the biomarker level has gone down and we should act. And so we decided to use this concept of value of information. Have people here heard of or used VOI, value of information analysis, in their work? Okay, so looks like mixed. And so VOI is basically, it's a concept from statistical decision theory, which quantifies clinical utility. So there's 2 parts to it. It says how likely is additional information to change the clinical decision? What's the probability that you'll make a different decision if you collect more information? And second, how will that change in decision impact patient outcomes, or what are the consequences of that change in decision? So, even if you have huge consequences, if the chance that that decision will be different is very low, then you have low value of information, and vice versa. So, in healthcare, VOI has been used a fair bit in the past couple of decades, especially to inform the value of collecting additional research studies conducting additional research studies, and to inform the value of conducting tests to guide treatment choice at diagnosis. What we're doing is we're extending those ideas to guide more individual level decision making regarding biomarker testing. So the decision making that VOI has guided for conducting additional research studies have been more population level decisions, in that if I was to collect more information, collect on a greater sample, can I reduce uncertainty in my treatment effect, which might then apply to an entire population. What we're doing is trying to improve individual level decision making above biomarker testing using VOI. And so our goal is, at a clinic visit, can we use VOI to determine at what time point direct collection of the biomarker would be most valuable? So it's still about collecting more information, but on a given patient. Any questions up until that point? Yes.
So this is sort of predicated on the idea that your threshold of 30% is the optimal time to transplant, right? I mean, are you thinking of building this work sort of on a platform of a decision analytic approach to sort of either at an individual level or for a cohort of people sort of define a different threshold, like a different optimal threshold for transplantation? Because I would guess that that's sort of a rule of thumb that clinicians have sort of employed without really thinking about the rate of mortality and the untransplanted, the outcomes, and those who are, I mean, it's probably not too far from the truth, but I'm just wondering if you use decision theoretic methods to sort of look at that threshold also. Yeah,
so I will talk a little bit more about that. In this case, I'm kind of presenting more preliminary work that still, it actually doesn't use the threshold of 30 to make a decision. It's basing it on the FEV value and getting at survival predictions with and without transplant. So I'll talk a little bit more about this shortly. And we're currently working on further expanding that decision theoretic framework to do exactly that, to really base it on the risk of patient for an adverse outcome.
So also the cost of the marker of the testing is incorporated into this valuable information, or it's ignored?
Yeah, so the cost of the biomarker, it is. So we do it in two ways. We base it simply on survival, on like life years gained, but then we also monetize it and compare it to the cost of the biomarker. So I will get to that as well. Okay, so the data again are annually updated data from the Cystic Fibrosis National Registry. And here to illustrate ideas, I'm actually going to fix the time of transplantation decision to year 2000. So what I mean by that is I have data from 1993 all the way to 2012. And what I'm saying is that I'm making the transplantation decision in year 2000. And can I use earlier biomarker values for making that treatment decision? So as opposed to collecting data right now, I use marker values from a year ago, 2 years ago, and 3 years ago. And so then the question is, what's the value of collecting perfect or updated biomarker information at t=0, which I'm fixing to be year 2000. And so we use the evolution of prediction uncertainty over time to determine the time point at which precise information on the biomarker levels would be most valuable. And I'll explain a little bit more about what I mean by that. And so, again, what we're doing here is we're extending existing VOI methods to patient monitoring and incorporating longitudinal biomarker measurements to extend it to dynamic decision-making and individual decision-making. So that's where we're headed with this. What I'm presenting is a little bit more preliminary than that. So again, if Y naught is my biomarker value that in year 2000, I'm trying to see if Y at -1 can be used to predict Y naught. Trying to see if Y -2 can be used to predict Y naught and Y -3. And then use those to make the decisions. So there's two parts to this that I'll talk about. There's the actual decision theoretic framework, and then there's the statistical prediction model. So there's modeling the biomarker trajectory or predicting the biomarker value, and then also predicting survival with and without treatment. So first, to outline the decision theoretic framework, what we're saying is that for each individual, if I'm using older information, YJ, to decide about transplantation, I let some UJ1 be the expected utility, where here I use the residual lifetime of under transplant, and so the 1 represents transplant, and then UJ0 is the expected utility under no transplant. And so then using that information, I would simply pick the decision that maximizes the expected utility, right? So value of the optimal decision would be the maximum of those two expected utilities. If my estimate of the expected utility from transplantation for this patient is higher, then I would pick that as the optimal decision to transplant. Okay, so that's the same thing as before from the last slide. Compared to if I did update the information, so if I have updated biomarker information, why not? What would I decide? And so, but I'm trying to make this decision about collecting the biomarker information without actually collecting it, right? So I don't have the information yet. And so I'm using earlier information to predict the current biomarker value, to predict why not. And so, okay, I'm going to step away from the mic, but what's inside these parentheses is still what was up here, but so based on why not, I would still use or choose the decision to be the one that optimizes my expected utility, but now I have to average that with respect to all possible values that I might observe for why not, if we do collect it. And so that's the expectation around that max. And what I use to get the distribution of all the potential values of why not that I might observe is the prediction error. Okay. So any questions about that so far? Okay. So then, if you are familiar with VOI, you'll be familiar with EVPI. But if you're not, all it is the expected value of perfect information, or in this case, updated information, which is simply taking the difference between those two last values that I showed you. So it's the expected value of the optimal decision that I would make with the updated information if I were to collect why not. So that's the expectation with the max using why not, and minus the value of the optimal decision with older information. And so that was the max of the two expected utilities that I showed to you using the older information. And so that difference then tells me the life years that would be gained by making a decision using the updated information. And then this addresses your question, Petros, about say the biomarker comes at a cost, C, then I can monetize that EVPI and using, say, 100K per life year, and then it would be optimal to collect the biomarker whenever EVPI is greater than C, greater than the cost of the biomarker. So I presented this decision theoretic framework that we're going to be using, and then the second part of that is the statistical models that are going to be used for estimation for the quantities that go in there. And so to get at the expected utility, I said that I was going to model residual lifetime, for which I need survival prediction. And to get at the prediction of the biomarker value at T0, I need the biomarker prediction model. So for survival prediction, again, I said that T equals 0 was year 2000, which is when I'm making the transplant decision. And we used just the Cox proportional hazards model. So this was actually a very simple implementation of the idea. And so I just used the simple Cox proportional hazards model. I used predictors of FEV1 measured in 2000. So I'm not using a cutoff of 30 or 40. I'm simply using the value of FEV in my model, transplant status, and other patient characteristics. And I actually used the AIC, Kaike's information criterion, to select the best model from a number of candidate models. And then for each patient, we predicted survival with and without treatment based on other similar patients. So what I did here was I actually, in my Cox model, I used stratification based on baseline FEV of less than 40 and greater than 40. So this is just, so even though I use the actual FEV value in my model as a predictor, I set the baseline hazard to be different based on whether you were sicker or healthier. And so, and we found that, you know, our model did pretty well in terms of predicting survival. So the solid curve there is the estimated, and the dashed curves there are the Kaplan-Meier survival.
So you're modeling lifetime survival, or you're modeling survival of 12 years? I mean, are you extrapolating beyond what you observed in the 12-year data?
Yeah, so I do. I modeled the mean residual lifetime.
Okay, and okay, but the baseline hazards cannot be extrapolated beyond the 12 years.
I did. So I used an estimator. So I think I used the Fresno estimator for the baseline hazard, which actually did allow me to extrapolate.
Okay.
And then I applied the Cox model on top of that to get at. And so I set the maximum age to be like 80 something, whatever the life expectancy was for males versus females, and then I extrapolated to the residual lifetime.
Okay.
How are you comparing years post-transplant in the people who didn't get transplanted? You got two curves there, the people who got transplanted, those who didn't. So what does it mean to have a no transplant 4 years post-transplant?
Oh, so yeah, okay, so how am I comparing, looking at no transplant years post-transplant? So, okay, so Y label should really be years since year 2000, I guess, years since when you would make the decision. Are you asking how I came up with the estimate?
I'm just wondering what those survival curves mean, that's
all. So, yeah, so this was observational data. And even though the guidelines, so the rough guidelines are, you know, you transplant if someone's below 40 and you don't transplant if they're above 40, people don't adhere to those guidelines. And so we actually had people who were below 40 and weren't transplanted, and people
Those are people who would have been eligible for transplant but didn't get transplanted.
Exactly.
Okay.
And similarly, people who shouldn't have been transplanted were transplanted. And so what we're seeing here is, you know, the top, those are sicker patients who should have been transplanted, and you see that when they are transplanted, they have better survival than when they're not transplanted. And then in the bottom are healthier patients who shouldn't have been transplanted. And so they do have better outcomes when they're not, but then when they are, they're poorer outcomes, just because of the morbidity that's associated with transplantation.
Could it be that the more healthy people receive transplantation?
More healthy people?
In the upper part, I mean, is it an effect of transplant, or is it because of the characteristics you have at baseline, you're more likely to receive transplant because you are healthier, and maybe the decision is going to be to transplant this individual rather than this one because this kind of thing?
Yeah, possibly. Yeah, possibly. I haven't, again, this isn't the most like elaborate model that we could have come up with. I did adjust for a number of variables that hopefully captured a lot of the sickness, but you're right, there might be some selection happening here. Yeah, so if a patient's too sick that they won't survive a transplant, they might just not receive it.
Yeah.
Yeah.
And those are the people who get transplants at 2000, year 2000, right? What about the ones that, did you include the ones that get transplanted later on?
No, I didn't include them for this, for the estimation, no. Okay. So that was the survival prediction. And then, again, we wanted to also be able to see if we can use earlier biomarker values to predict the current biomarker value. And so for that, again, I just use a simple multiple linear regression model where the outcome was Y naught, which is a biomarker value to 2000. I had the previous biomarker value and other patient characteristics. And so I just selected a model that minimizes the mean squared error, and I used tenfold cross-validation to avoid overfitting. And looking at the predicted biomarker value, you see that, so if you're using, so going from right to left here, the point on the right is the current biomarker value. That's the value we're trying to predict. So, the -1 is representing the biomarker value that was a year old, and we see that, there's no bias on average across patients, but all these values are unbiased, but the error is increasing over time. As the biomarker value that you're using for prediction gets older, there is greater prediction error as expected. And so then we extended that to also looking at what if you use one additional past measurement to predict. So not just one previous measurement, but two previous measurements. And so if you were under a 2-year schedule, a 3-year schedule, or 4-year schedule, and so the model there, I just added the additional biomarker value as a predictor in my model. So again, this was very simple initial implementation. And so then that's the result that we got for the EDPI. So when we plugged in these estimates from the survival and biomarker prediction models into our decision theoretic framework, we saw that first, if you just focus on the solid curve that's using just one past measurement, we see that the value of annual biomarker collection is pretty high. So if you were, so it's pretty high, but then if you look at the dash curve, then when you add another additional measurement, then it's not quite as high. It's just when you capture patient history a little bit more, that reduces the value of annual collection. Then we put that in terms of dollars, and so recall we said that it was optimal to collect the biomarker whenever EDPI in dollars was greater than the cost of the biomarker. So here, if the cost of the biomarker collection was some unrealistically high, like 45K, then using just a single measurement, so look at the solid line, updating would be worthwhile at the 2-year mark, because at that point your EDPI is higher than the cost of the biomarker. And if using more than one past measurement, then it's worthwhile to update the biomarker at the 3-year mark. In cases where the biomarker is not very expensive, so that's the dashed line representing $100, it is worth it to just collect the biomarker annually. Because the gain that you get, the EDPI, is much higher than the cost. This is more like a proof of concept to show that BOI, or decision theoretic approach for determining the optimal time interval between updated biomarker data, is feasible and could be applied to other settings as well. I presented this initial work at ISPOR, which is the International Society for Pharmacoeconomics and Outcomes Research, and it did receive good feedback. And so then we took this idea and we worked on extending it. And so over the past year, I wrote this grant, which where we're actually looking at 2 major aspects. So what I presented here was just looking at the timing of biomarker measurements. but we're also looking at the timing of treatment. And so, we said that among low-risk patients, can you wait to test their biomarker? But among high-risk patients, you might use the same idea of predicting and say that, okay, this patient looks like they're at high risk of an event in the next 3 months, so let's treat them now. And so you might actually improve their outcomes by intervening earlier than you would have if you waited till they actually crossed the threshold. And so here I fixed the timing of treatment and just focused on the timing of biomarker measurements, but been working on putting together a more elaborate decision theoretic framework which incorporates the timing of the treatment as well. And it also then, looks at the risk of the patient for prediction. And so that it doesn't just say that if you're above a threshold or below a threshold, it tries to optimize the risk threshold as well as part of the decision theoretic framework. And so we call this the personalized risk adaptive surveillance in cancer. And we're focusing on cancer post-treatment surveillance, focusing on colorectal cancer, prostate cancer, and chronic myeloid leukemia. And so I talked about this a little bit. The idea is that if we can accurately predict high versus low risk patients, then low risk patients might undergo less frequent monitoring, whereas high risk patients might be targeted for more frequent monitoring and aggressive treatment if they're expected to benefit from treatment. And so we actually also take into account treatment benefit. And some ideas that we use there are this dynamic risk prediction. So it's using the biomarker trajectory up until a given time point S. So here I kind of presented proof of concept, saying that, okay, if I do use more than one measurement, so if I use 2 measurements, that can definitely improve my value. And so we're using statistical methods to capture that trajectory. And then, so that's using a linear mixed effects model, and then getting the prediction from that mixed effects model and inserting that into a risk prediction model to get at the risk of an event within some given time frame. And that would be done on an ongoing basis. So as you collect more information on a patient, you can update their risk predictions. And so things to consider here are that the biomarker value might change over time, or the risk score might change over time, the accuracy might vary over time, and the utilities, the treatment benefits and harms may also vary over time. There might be greater benefit early on and lower benefit later. So the framework takes that into account when deciding the timing of treatment. And then we're using causal inference methods for estimating the treatment effect. So recognizing that we're using EMR data for all of this work, and so recognizing that there is going to be selection bias and confounding. And so again, we would try to use causal inference methods to try to get at the treatment effect using sort of a potential outcomes framework, which uses similar patients to the patient you're interested in to estimate their outcomes under treatment and without treatment. And then the key issues that we're trying to address are to leverage longitudinal biomarker information instead of just the latest information, and then to also dynamically tailor surveillance schedules. So if you're told to come back in 3 months today, you might come back in 3 months, and then you could be told to come back in 6 months. It doesn't have to be fixed schedules for the same patients. So there has been work done in this area, but that work uses like latent class models, which puts patients into risk groups at baseline, and it says that you'll undergo the same schedule for the rest of your monitoring. But what we're doing is sort of tailoring that schedule over visits as well. And then the goal is to optimize use of healthcare resources using this work. That's it. That's all I have for now. Happy to take any questions.
Well, I'm thinking that trying to think of which cases this kind of methodology would be most useful, in the sense that if you have a biomarker, or if you have I'm thinking imaging, for example, would be could be biomarker could be replaced with imaging possibly as a
absolutely.
and you have low yield, high cost.
Yeah.
In situations like that, maybe the BOI approach would make more sense. I mean, in pediatric oncology, you're screening or you have surveillance for kids that they have a predisposition for cancer, but you don't really know what you're searching for. So you're sending kids every 3 months or 6 months throughout their lifetime for MRI screening, MRI, which is very expensive and with a possible utility decrement as well. And the yield is very low. So would you say that in situations where you have like low yield, high cost cases, this BOI approach would be more
Yes. I mean, the example that I gave of FEV and cystic fibrosis is actually not a great example because the cost is pretty low. But it's kind of just a motivating example for the methods. But in cancer, so the grant that I submitted and got a good score, so I'm hoping it'll get funded, but the primary example was colorectal cancer. So colorectal cancer, after patients are treated, then they're under surveillance. And, biomarkers I used are this CEA, which is a blood biomarker, and there's also CT scans that are done, the imaging. And one of the questions is, CEA is easy to measure. It's just a blood-based biomarker. Are scans adding anything beyond that, beyond just looking at this blood-based biomarker? And so, yes, that's exactly like what you described, where, we're asking the question, in addition to frequent collection, also, like if you were to double up on these biomarkers, is there added value of doing imaging if you could just do a simpler biomarker test? Also, there's one thing that we're also looking at is the accuracy of these tests. So blood biomarkers are not that accurate. There are issues about sensitivity and specificity, especially the sensitivity of these biomarkers. And so CEA testing is cheap and it's done frequently, but the decisions that are made based on it might not be the best decisions because of its accuracy. That's not always taken into account. And so this would also, the framework would also take into account accuracy of the biomarker in addition to the cost. Yeah.
Question. This might not be the right question, but I was thinking how this can be used, like how certain you are in these models, like individual based. My thinking is like in Canada, we have public healthcare system, like I can see physicians using this tool and arguing with like one healthcare provider, like ministry, I could say, my patient really need now to go to this treatment or to dispensing because of this. And I know in US it's not like that straightforward. There are multiple providers and it may be used by insurance companies rather than, it used in a, not in a way that you are thinking.
Yeah, the data are messy. Like you've got same patient going to different providers for different tests potentially. So I'm actually using data from Kaiser Permanente, which is, so they have their patients, they're just an integrated system and everything is done within Kaiser. So their EMR records actually contain all this information. But you're right, like, I'm not quite sure. It would be a data nightmare to have to try to get all that information if a patient was going to different providers and stuff. And I haven't really thought about that too much.
Decision makers to use it kind of.
Yeah. I mean, then again, I'm not sure. I mean, if a patient is under the care of a provider after they've undergone cancer treatment, for example, I don't know how likely they are to go to different providers or if they just tend to stick with same longitudinal care. That's not my area of expertise, to be honest.
Kind of the same question I asked before. I mean, if you're calculating BOI, you need an expected not only survival gain, but you also need an correct estimation of expected cost difference between the two. And so you can put in the cost of the biomarker, but you also need a model of disease and looking at resource utilization over time. Transplant when it occurs. For example, to use this example, transplanting people when they're sick versus when they're not so sick. building out the back end and sort of like a proper sort of decision analytic model.
Yeah, no, you're right. There's, yes, this was very simplified. And so there would be a number of other costs to consider, which we are, so this is all going to be built into a microsimulation model, where we're hoping to incorporate other costs as well. Yeah, so that is the plan. I am not an expert on costs, so I can't speak to a cost, but my co-investigators are health economists, so they tell me we're going to take care of it.
All right. There are no more questions. Thank you very, very much. Thanks all for coming.